And I'm Mike Caudle. I'm the chair for the Primary Care Technical Advisory Committee, excuse me. Before we, first thing on the agenda is welcome introduction. And let me say this, at this time, I would like to give out congratulations and condolences to Molly Lewis. Congratulations, because in a special call meeting yesterday afternoon, following a very intensive interview of multiple applicants, Molly Lewis was selected and given the position of permanent CEO of Kentucky Primary Care Association. The condolences is because yesterday afternoon, in a special called meeting, Molly Lewis was given the permanent position of CEO of Kentucky Primary Care Organization. So, Molly, congratulations, and we look forward to working with you and have every confidence that you're going to do a great job, not only for KPCA, but also, since this is Primary Care Technical Advisory Committee, in your relationship with DMS. Thank you. Teresa Cooper, would you care to establish a quorum or call the roll, please?
Mike Caudle.
Here.
Barry Martin.
Here.
Rainer Mullins.
Here.
Yvonne Agan. Yvonne Agan. And Chris Kaiser.
Present.
Mr. Chair, you have a quorum.
All right, a quorum is being declared. And next will be the approval of agenda. And before I ask the motion, Teresa Cooper, I believe you had presented something in the interim concerning one of the speakers has a schedule, not conflict, but tied and would like to be able to be heard out of turn. Is that right?
Yes, sir. We have Dr. Julia Richardson is going to present on doulas, and she has a patient schedule she needs to keep. So we would like to move her to the top of the agenda if possible.
All right. Would that placing her after the approval of minutes, would that meet with the pleasure of the board?
Yes.
Yes. Yes.
Barry? Okay. Okay. All right. We will allow that to take place. With that change, is the agenda, can the agenda be approved as presented?
This is Chris. I'll make that motion.
Have a motion made.
Second.
I'll second it. Oh, okay.
Either one.
Seconds, Raynard. All right, all those in favor say aye.
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 All those opposed say nay. The agenda is approved as presented with the modification. We have item 4 is approval of minutes from the previous meeting. And just to clarify, the department has changed recorders, and the current recorder does not provide us with a set of minutes like the second one did. So now the KPCA has agreed to and is providing us a summary in lieu of that. However, the actual minutes is the transcript itself, which is presented out here to everyone. With that in mind, is there a motion for the approval of the minutes in the form of the transcript from the previous meeting?
So moved.
So moved by Barry Martin.
Yes.
Second.
Seconded by Chris Kaiser. All those in favor of the approval of the minutes as distributed, say aye.
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 All those opposed likewise. There being no objections, the minutes are approved. Now, at this time, if Dr. Richardson is on, I would invite her to make her presentation on the doula presentation.
Thank
Dr.
you.
Richardson, are you on?
I am here. Can you hear me?
Yes, ma'am. Would you please go ahead with your presentation?
Absolutely. I'm going to try to share screen. Can you see my screen?
Yes.
Okay, sometimes when I do this, I don't advance the slides properly on Zoom, so let me know. So thank you all so much for giving us some time this morning to talk about a really important topic for our families in Kentucky as well as for Medicaid. And so we're going to talk about Kentucky's families and their first birthday. We talk about that concept often when we talk about infant mortality. And today we're going to talk about wanting all babies and mothers to celebrate those first birthday parties. And so I think everybody on the TAC knows me. I'm Julia Richardson, and Kasia Bryant is joining us as well. And she's going to make comments midway through, and I'll let her introduce herself during her comments. Our plan is to speak for about 10 minutes, but we have some time for questions and answers if that fits into your agenda. Can you see my second slide? Okay, so why do we need doulas? I think it's important to know why I'm interested in this topic and why I'm asking to be on the agenda today. So that's me pregnant in labor and my little girl when she was about 1 year old. So I was 40 when I gave birth, 40 when I gave birth. I was on bed rest for 9 weeks. My closest family was over an hour away and 3 hours away for the rest of my family. The only labor help I had was my husband. I had zero nursing support because I think there must have been 15 C-sections going on at the same time. And so my nurse would pop her head in the door and say, "You doing all right?" and leave. My OB, who I knew because she was a neighbor, she was another white woman, she prevented my C-section. She came in and said, "All right, if we don't get this baby out in 30 minutes because you've been laboring for too long, we're going to have to do a C-section." If she had not done that, I would have had a different birth outcome. So clearly I had a complicated pregnancy and potentially a complicated labor because I had no support. And so I always recommend doulas for families. And I think if we all reflect on our friends, our families, and their birth experiences, the support we need during those periods, during pregnancy, delivery, and postpartum is extremely important for all of us. So what is a doula? According to the international organization called DONA, a doula is a trained non-clinical professional who provides continuous physical, emotional, and informational support to a pregnant person before, during, and after childbirth. Few health plans cover this cost, and it can range from a few $100s to well over $2,000, making this really not a mainstream approach for most families because of the cost. So why in Kentucky? Why is this important to us and for us to discuss today and for Medicaid to be in the conversation? So this is the resource there, the reference is there. In 2018, Kentucky's maternal mortality rate was 40.8 per 100,000 live births, significantly higher than the national rate of 17.4. Also, 78% of maternal deaths in Kentucky were identified as preventable, compared to 60% at the national level. So we have an amazing opportunity in Kentucky specifically to turn this around. Also, this is from ACOG, so the American College of Obstetricians and Gynecologists. This was their committee opinion called Approaches to Limited Intervention During Labor and Birth. It was written in 2019 and reaffirmed in 2021. So they feel OBs feel evidence suggests that in addition to regular nursing care, continuous one-to-one emotional support provided by support personnel such as a doula is associated with improved outcomes for women in labor. Oh, lost my place. I think we're up to Kasia. Okay, so Kasia is joining us today. She is a full spectrum doula, executive director to Mama, and an amazing advocate for women and families. And so I invited her to join me today to talk a little bit about her work so you can get some firsthand information. Keisha.
Like Julia said, my name is Kasia Bryant. I am a full spectrum doula. I have been a doula since about 2012. I am also currently a midwifery student. And so that for me was the next step after being a doula for so long. The clients that we serve are generally families who cannot afford that cost to cover a doula at Mama to Mama. And so our program is grant funded. And what that looks like is perinatal support. So that's support all around the pregnancy. We have community baby showers, we have childbirth education classes, and we do have that one-to-one support for our clients. And that's important, especially in a time where, as a doula myself, I am seeing a lot of inductions. And a lot of times those inductions happen when naturally the body is not ready to deliver a baby. And when you get on that cascade of interventions with inductions, that a lot of times is an express lane to a C-section, which none of our clients really want to go through. And so having that one-to-one support, we are able to educate our clients and prepare them for inductions. We take a more holistic approach. And so we're able to implement things leading up to that induction that could potentially prepare the body for an easier, more productive labor and delivery. Lessening those interventions during labor and delivery, it does decrease the adverse effects of what can happen, things that lead to maternal death and infant death before that first birthday. And so having our clients be educated about what birth looks like, what birth and labor should be, creating a safe space for them, because 98% of our clients are women of color. And so with more and more light being shed on Black women dying during labor and immediately postpartum, going into the hospital space, it doesn't necessarily feel safe for our clients. And so having us present and having us be a shoulder to lean on, sometimes a second opinion and a reassurance, is comforting, because birth is a full body process. It's hormones, it's mental, it's physical. And so if one of those key components is out of whack, then labor can stall. The hospital puts you on a time clock. If you don't deliver in a certain amount of time, we're looking at a C-section. And so being able to lessen and ease that anxiety for clients when they go into the hospital setting, knowing that they have someone there outside of family who does this on a regular, it definitely promotes better outcomes for our birthing families. This year, I have been collecting a lot of data because we are part of a pilot program with Anthem Medicaid. And so we look at birth weight, we look at C-sections, we look at the number of interventions our clients are having, initiating breastfeeding before they leave the hospital. And what I've seen in the data is our clients who have a doula present, those babies are being born at birth weight, no low birth weights. I think we only had 2 out of the whole year so far. A limited number of C-sections, and just an overall better outcome mentally and physically for our moms who are having babies.
Thank you, Kasia. So why are we approaching this group? So why do we need Kentucky Medicaid's help? So again, the reference is there, and I've got some references at the end for your review, but doula care has not only been linked to lower Medicaid costs, but shown to improve birthing experience and birth-related outcomes of birthing people of color in underserved communities, just like Kasia is telling us she's seeing firsthand. Most importantly, doula services can help address current racial disparities in care by providing ongoing culturally congruent tailored care, education, and social, physical, and emotional support. The Georgetown University Health Policy Institute has done a lot of work on doula services and the research around both the funding mechanisms as well as the clinical outcomes, as well as the National Health Law Program Medicaid Doula Medicaid Project, a really good resource. So 6 states currently reimbursed for doula services in Medicaid. 6 states are planned to get CMS approval to implement in 2022 and 23, and 5 states are considering. And on the National Health Law Program Doula Medicaid Project, it talks about how they're doing that with spas and looking at appropriate payment rates and all of that. So the resources are there to be reviewed and learn, and we can learn from. So I didn't mention that I'm a pediatrician in the beginning. So those of you who I haven't met, so this is extremely important for us as pediatricians in the state, as well as the OBs, as well as the community partners and doulas like Kasia and everybody working in this space. We know how important it is. So I know you all know this. I know that I'm not telling you anything that isn't new. Maybe you learned a little bit more about doulas. I hope so. So I would like to take a minute to talk about next steps. How can we continue this conversation and follow up? We know that there is active discussion within Medicaid. Aside from the Anthem project that Kasia mentioned, and Humana, I believe it did a community grant. I'm not sure their funding as well, but some small pilots. I think we've really got some great national data and people moving forward. We know we've got huge disparities. We know we've got maternal and child health outcomes that are not where we want to be. So I think, the question that I would love to ask today and find out is who's the lead on this within Medicaid, and how can we help support you all in this work? Because I know it's important, and we're in the community and want to support the work that Medicaid is doing in this and help to facilitate and expedite it. Another idea just put on there is, could this be a PIP to help the MCOs prioritize this work? Last slide is just some references that I mentioned. The Commonwealth Institute of Kentucky issue brief on maternal mortality in Kentucky, really 10 pages. You've got all the baseline information that you need to learn more about this, and then some other websites. So I'm going to stop share, and just a thank you. And if we have a moment for questions, I know we're happy to answer any.
Julia, this is Rainer. I have a question.
Yeah.
In a former life, I did some work with the cabinet on a program called Centering Pregnancy that had a group component. And I'm curious, Kasia, about if in your, classes before delivery and after, if your program has a group component. Because one of the things that was very successful was a parenting group that following delivery, and I know the pre-classes were an important part of centering. So I'm curious about the doula program and how, if you plan to use groups.
So we stopped doing groups during COVID for obvious reasons.
Sure.
And then during COVID, we kind of went through an overhaul, and the end result of that is me becoming the executive director at the beginning of this year. And I've had a lot of moms reach out to me and say that that is a need that they have. And so one of my initiatives for 2023 is to re-implement the new moms groups, where moms can get together and connect and be together in community, because I do think that that's important, because honestly, people of color, we really don't have spaces where we can get together and talk about some of the things that we go through. So I do think that that is important, and that is really something that's high on my priority list.
Thanks, Rainer. And I think it's fantastic, and just another example of something that's not funded, right? There's so much work that we do on the side It used to be our diabetes educators, right? Those were, we would just piece things together, or gosh, I don't know, there's any number of things that we just try to piece together with this grant or a little bit of that grant, or maybe somebody's just really good at it, so we're going to have them work overtime. And all of these things are so vital to be in the community and to be funded and supported on, with not from grant to grant.
Julia, this is Chris. I got a question for you and or Keisha. While I have a very limited understanding of doulas, can you speak to, is there a national certification or is it a state certification? And, in getting, in seeking, I guess, reimbursement from Medicaid, which is, what you're leading to, are these individuals under, a staffing as a licensed professional in some capacity, and are there other current professionals in Medicaid that Medicaid reimburses for that, fall into a doula category as well? I just wanting to, to understand better.
So as far as certification, this is actually something that I brought up when I had a meeting with the president of Anthem Medicaid. Like I said, I've been a doula since about 2012. And in doing that work, I never got certified because it's not necessary, because it is a non-medical. We don't perform, we don't take vitals, we don't do cervical checks, we don't do any of that. Now I did receive training through DONA, but I never went through with that certification because it was 9 years later, I had already been doing the work. And so being a competent and fully functional doula is not contingent upon a training class. It's based on experience. And that is a concern that I have, because DONA is nationally recognized for training, but that's not the only entity that somebody can be trained in. Because at Mama to Mama, we hold our own doula trainings. And we go through everything. We go through stages of labor, postpartum. We cover all the things that DONA covers. We're just not nationally recognized as a training entity. And honestly, as a Black woman, that's a barrier, because it's expensive to get trained and get certified and keep that certification. So the goal at Mama to Mama was just to make that training accessible, and that could be a barrier for some folks. I know my doulas at Mama to Mama are not trained through DONA. They don't have any certification. They're literally just boots to the ground doing the work.
Understand. And it, it is, I think, very much essential. I guess my thought is that, and of course I don't speak for Medicaid, but is that a concern to them? I have no idea how they, decide what group of professionals to bring in, or, to add to their list of services. And I know that, nurses have to be licensed, PAs, et cetera, et cetera. So I guess I'm just wondering if maybe that, would be a hurdle. And if there's somebody from Medicaid, Julia, I'm sure you'd like to hear some comments from them to see, as you said, is there, who is taking the lead, who is working through this, and what's happening at this point.
Yes, I agree. I don't know who from Medicaid wants to speak to that, but yeah, every state's doing it differently. There's a lot of best practices out there, but I don't know who within Medicaid is kind of watching how other states are doing it and what might work for Kentucky.
We have been looking into this, and I think the deputy commissioner can answer better than I, but that is a hurdle, paying, non-medical people Medicaid funds that you can't, that are not certified. That is one of the things that would have to be dealt with. But this is something definitely that we're looking into.
And certainly the community health worker work that you're doing as well, side by side, can lend some information to how to best bring the community resources we need, support them with Medicaid dollars, and do it in a way that works for everybody.
Mm-hmm.
This is Justin Derringer with the Division of healthcare policy. We have a position within our child and maternal health branch. That position is takes several different responsibilities and duties, but one of those is with the role of in the full spectrum of midwives and pediatricians. And one of the things that they were tasked with was doulas, and researching doulas, the role that they play, how or if we can expand Medicaid to help provide for that service. And in that role was a large amount of research, looking at other states, other national organizations, seeing how other states were paying for it, if they had certification requirements, what other states had trainings in place, and different things like that. The individual it's a very new branch. That branch just started, and that position actually is a brand new position that just started less than a year ago. I'd say about 6 to 8 months ago, something like that. And the individual that had started in that position resigned, and that position is currently being filled again at this point. So that position is very much, in action, in service. We're still following that information. We're still gathering that information. The branch manager is Erica Davis. She is responsible for that branch. And she's, I'm sure, doing some of that work and continuing some of that right now. But as soon as that individual is hired for that position, we'll continue moving forward as fast as we can because we understand this is an important topic, and you all aren't the only people that are interested in it. We get questions all the time about doulas and their role and how can we provide assistance and help. So we're very much aware of it and are actively pursuing the research that we need be able to show and to be able to support any type of doula program that we may fund here in Medicaid.
This is Veronica Judy Cecil with Medicaid. Just to maybe add to what Dr. Terrio and Justin just said, this has been a subject matter at other TACs, Nursing Services TAC. The MAC is very interested in it. We are, Dr. Terrio is leading a deep dive into maternal health and has been doing that over the past year. We've made some strides, and some of that is post pregnancy, and that's the 12-month postpartum, which we were super excited to get approved and implement. We believe is a really important step to improving outcomes. And we are focused on pre-delivery. So looking at maternal health in general, in terms of timeline, I think the difficulty that we always have in Medicaid is there's more work than there are people and resources. So, we do have to take that into account in terms of how quickly we can move forward on things. I will say that the other thing we're interested in very much is the pilots that are being performed by our MCOs, because while we have all the national data and what's going on in other states, really being able to see what's going on here in Kentucky and the how that's working and the outcomes that come from that really are kind of more important to us to determine what steps should Kentucky take. Because when you see one state Medicaid agency, you've seen one state Medicaid agency. We're not all the same, and our population's not all the same. So it's important for us to monitor that and get feedback from the MCOs about how those programs are going to inform our next steps. So again, we're aware of the interest in this benefit, and we are continuing to research it, and there is no set timeline for implementing it.
Veronica, this is Dan Brunner with Anthem. We've had a really good experience with the doulas we've been funding, including Mama to Mama. We've done that through 2022 and plan to expand that in 2023. So we've had excellent results, and we thank you guys.
Thank you.
Okay.
Let me mention, and I know, Mike, we need to move along. mention one other thing, and that is, and I'm not familiar with how this is being implemented in other states. There is generally a requirement by CMS for a practitioner, even a paraprofessional, to be certified. And so in some way, form, or fashion. So, part of our research, obviously, we'll see how other states may be implementing that, but certification is likely going to be a requirement and have to be supervised by an enrolled licensed practitioner.
Dr. Richardson, any closing comments you'd like to make?
No, just thank you all so much for the time and for the feedback. And we really want to stay in conversation so that everything you're doing is reflective of the community's needs and the priorities and the community voice. So we know you will do that and we appreciate it. And I don't know if you all want to have a placeholder on this agenda for follow-up for the PCA to stay involved in the conversation. But thank you for your time.
Okay, the board have any further comments or anything they'd like to say about this presentation?
I think it would be good to have a placeholder, Mike.
Okay,
On the agenda.
then let's put a placeholder. Let's not make it a monthly one. Let's put it up to, say, our March meeting to give a little time for things to progress and take place. Would that be all right?
Sounds reasonable.
Okay, all right. So Teresa Cooper, if you would, make sure we include that in our summary of minutes and on the next, on the March agenda. Thank you very much. And thank you, Ms. Bryant, also. I'd like to move on then to item 5A, a crosswalk from MCOs pertaining to SUD benefits. Those you following can find that on transcript page 11. But more particularly, Veronica, at the page 16, you said right now I'm asking MCOs to email us if they have additional things that might not be on that value added that are specific to SUD patients in recovery. So that kind of puts you on a follow-up as to what results, and perhaps you get better luck with dealing with MCOs than I do with my own staff when I ask something like that, but please go ahead.
Sure, thank you. So we did collect information, and I apologize. We're trying to put it in a comprehensive, user-friendly format to share. So we'll get that out to the TAC members. It shouldn't take us very long to finish that. And the other request from the last meeting was about something from the department that explains SUD benefits, like in a one-page handy thing. I want to quickly show you what we pulled together for that real quick here. And we'll send this out. So there's it. We want to make sure we're meeting your needs. So because it can be kind of difficult, but this is, so what we did is we moved to utilizing the ASAM levels of care, and that's the Society of Addiction Medicine. And they are the ones who determine what the level is and what services are provided at that level. So we've already implemented that. So what we did was pull this together, and it goes through what the services are based from the level of care perspective. So wanted to share that to see if that is what you all were interested in seeing, as in terms of just something to be able to pull out and quickly see what the SUD services are. I'm trying to scroll without making you all sick.
Board.
And we
members.
certainly can share this, and you all can take it back and see if it's what you were interested in, and we can work to edit it based on your all's feedback.
the board have comments?
So I just, Veronica, this is Chris Kaiser, just wanted to clarify. So this is Kentucky Medicaid's overall, items that are covered. So are all the MCOs supposed to cover these things as well? Everything that's listed?
That is correct. Yeah. So these are Medicaid's covered services, and all managed care organizations are required to provide or cover these services or reimburse for these services. And like I said, what we're trying to pull together on a separate document is MCO specific additional
Gotcha.
coverage,
Yes.
value added coverage that comes with their SUD benefit.
From my standpoint, I think that that's excellent what you've done. However, what you're referring to is part two, the individual MCOs offering is a very important part of it too, that we're, I believe, all looking forward to being able to get it, because it does differ from MCO to MCO, and some of it is really great stuff, and at least from my standpoint, I certainly want to be able to distribute that to my providers, so that they can have that discussion with people who are eligible, and make sure that they're aware of what all they're entitled to. Okay, any other comments for Veronica? Then let's go down to 5B, update on provider signature regulation. The last time at page 21 of the transcript, Jonathan Scott, who is on the regulatory legislative advisor to DMS, spoke about the timetable, and some of those dates have now changed. If Mr. Scott is on here, would he care to update us? If not, Veronica, maybe yourself or one of your other people could stand in.
Good morning. I'm Jonathan Scott, Legislative and Regulatory Advisor for DMS. The reg is continuing to move through the process. We have deferred it last month. We're going to defer it again this month. We need to make an agency amendment to it to add a couple. We want to make sure that RHCs have an additional benefit that we're in the process of creating. So that's the only thing. So in the meantime, when it comes to provider signature issues, we would continue to point to 907 KAR 3005 section 2 for to meet the to allow you to go forward at 72 hours. So that's what I have for you on that one. Hopefully it will move through ours next month with some additional language that we need to add. And then it will go before the House and Senate Health and Welfare Committees after that.
Because it's still pending right now in front of the Administrative Regulation Review Subcommittee. Is that correct?
That's correct.
Okay. And you're still on date to have that in front of Health and Welfare in November?
We anticipate that it will be in front of Health and Welfare in January. The Health and Welfare Committees in January. We're going to defer the reg just because we need to synchronize some language with the SPA that we're about to file about an additional mental health benefit. So while it's sitting here at ours, we want to make some changes to make sure that it isn't out of date the minute we get it effective. So that's what's going on. We're just parking it at ours right now.
Okay, so our next meeting is January and January the 5th, and we'll ask you back at that time to give us an update on the status of that. Okay.
Sounds great.
All right.
Jonathan, this is Chris Kaiser. Can you repeat the KRS statute again, please?
So the the provider signature alternative that we're pointing to is 907 KAR 3005 section 2.
Thank you.
And the title of that reg is physician services, but that's really not the best title, because section 2 applies to all providers.
I understand.
Any further comments or questions from Mr. Scott? All right, item 5C is update on public health emergency wind down process. Those who are following in transcript may want to go to page 20 for Veronica's update on that. And then in that last meeting, she was talking about how the process was going on about unwinding it, and that they had hired a new consultant, taking the next steps of engaging stakeholders and providers, as well as advocacy organizations, the MCOs, and process of being more transparent. So I don't want to steal all your thunder, Veronica. I'll let you go ahead.
Thank you. I think the most important news, excuse me, is that they did extend the public health emergency. It now goes through January 11th. We are anticipating, or CMS is required to give a 60-day notice prior to the end. And so the date the date that they would have to get that to us is November 12th. So we're waiting for another week or so to see if we'll get that CMS notice. If we do not get the 60-day notice from CMS, then states are to anticipate another extension of the public health emergency. So really what that means is, thankfully, it gives us additional time to continue to work. What we've been primarily focused on is system changes, making sure that when the public health emergency ends, we're able to flip the switch and go back to pre-pandemic, pre-PHE. And so that kind of had been our primary focus, but now, as well as coming up with a plan to, it's really about supporting the beneficiaries, the Medicaid members, through the redetermination process, because some of them have never done it. Some of our Department for Community-Based Services workers have never been through a redetermination. They've never done one. So we've been focused on training and education around those areas. We have started our stakeholder engagement. We have a very long list of associations that we're reaching out to. And Kentucky Primary Care Association is certainly on that, as well as some of the other larger statewide organizations like the Medical Association, Nurses Association. So we're working through that list and trying to establish communications with those provider entities. It's because we really want to both get the feedback from you all on what you need from us to support you all throughout the unwinding. What we're hoping is that certainly you all providers would be on the front lines for us and trying to help our Medicaid members navigate that as well. So we think it is absolutely important for providers to understand what's happening and how can we all support beneficiaries through this process. So that's, excuse me, that's what we're working on right now.
Okay.
Veronica,
Next thing on the, yes, please go ahead. I'm sorry.
Joanne. So Veronica, I'm trying to get the timeline. So the providers are going to know at least 60 days before the changes are made. So they have time to make changes within their own organizations if they need to.
That's correct.
Okay.
Yes. So I would say 60 days or nearly 60 days, because, once we get the notification from CMS, then we will start sending out. We can't do it probably same day, but within that week, we certainly will start sending out communications and notifying providers and and working through our communication plan on making sure everyone understands what that means, because there are some flexibilities that'll go away. They have to go away as soon as the public health emergency ends. And what we're trying to do is make sure that we're communicating with everybody about that impact. So with it, within a pretty close timeline to the notice that we get, then we'll start communicating with folks.
Is there particular things that you feel is going to be going away in that you could share with us?
Probably not affecting really anybody connected to this TAC, but we did have some providers temporarily enroll. That was a flexibility that was afforded. So we do have some providers who are temporarily enrolled, and they would have to then move forward with permanently enrolling, and they could no longer submit claims if they have not gone through that process. We did, halt required revalidation. Some providers went ahead and did that, but we did halt the requirement. So revalidation for the 5-year revalidation for providers would go back into effect. There were some alternative location flexibilities that we had. So I know that we had a couple of substance use disorder providers who at the beginning of the pandemic especially needed to isolate COVID patients, and in order to find space for that, they used a facility that hadn't gone fully through all the licensure and credentialing requirements, but under the PHE flexibility, we were allowed that to happen. So those are a couple of the things that come to mind that affect providers that I can think of off the top of my head.
Okay. Any other questions of Ms. Cecil? All right, then let's move on to item 5E, in-person meetings. And that was deferred at the last meeting for a date to be set to bring it up again. And so let's set that for our March meeting to put that back on the agenda and see where we are in that. Then let's go to 5F, follow up on dental workforce recommendation by Veronica Judy Cecil and the current state of Medicaid. Let's see. Do you want to wing that to start, or you want me to kind of talk a little bit more about where we at in that, Veronica?
I have a presentation. I think what I committed to do was walk through a presentation that the commissioner did to the Kentucky Dental Association, because I think it's really great information to share with you all, given your interest in the dental benefit. So I will.
Dr. Julie McKay be making that presentation on your behalf?
I'm going to talk about Medicaid. Dr. McKee is going to talk about the workforce, the dental workforce issues.
So we'll pick her up then in new business where she appears on the agenda.
Yeah. And I'm going to do my best, Dr. McKee, not to steal any of your thunder. Let's see here. I want to share.
Mike, if I might make a suggestion, it would be helpful, I think, to have these presentations back to back. It would facilitate follow-up discussion, I think.
Okay.
It's part of the same issue, I think.
You suggesting we let Julie follow up with her presentation at the end of Veronica's discussion.
Or if Dr. McKee is ready, I'm happy to let her go, because she's going to do the state workforce in general, and I'm going to be focused specific to Medicaid. I don't know, Dr. McKee, if you're.
Is that the pleasure of the board?
Yes.
All right, no objections. Ms. McKee, or Dr. McKee, I'm sorry, would you like to go ahead with your presentation?
Yes, thank you very much. I'm actually going to hand it off to our epidemiologist who did the study, and that's Lindsay Metters. And I think that you all were kind of prepared to let her take over the screen. She's the one that, I mean, we both worked on it, but she had the final design of the questions. She collected the data, and she has presented this other times as well. And so we can do that, and then we can, and it does have some Medicaid questions. Actually, we presented to the dental Medicaid TAC. And Lindsay Metters is our epidemiologist. She's been here for a while, and my goal is to wear her out, and I haven't done that yet. So Lindsay, if you go ahead and take over, and then we'll take questions at the end, if that's okay.
All righty. Can everybody see the screen, the presentation?
Yes, we can. Lindsay, your volume is not as good as it usually is.
I don't know why that is.
Okay, we'll just make do.
I'll try to talk louder.
Okay.
Good morning. Like Dr. McKee said, my name is Lindsay Metters, and I am the oral health branch epidemiologist. Today, I'm going to share with you the results from our fall 2021 Kentucky Dental Practice Survey. The survey was designed for the actual dental practice. This means that one single dentist may have completed this survey more than once, depending on whether or not they have multiple practices in the state. The survey asked questions ranging from location of the practice, dental specialty, and numerous Medicaid questions. The objectives were to glean information about the dental practices, observe the attitudes, perceptions, and behaviors towards Medicaid, access to care, and to identify the challenges dental practices have towards accepting Medicaid. This survey was distributed to 3,140 licensed dentists in Kentucky, regardless of their specialty. We received 391 responses to give us a response rate of 12.5%. There were 64 surveys that were returned incomplete or partial, and the data from those surveys were accounted for in our data analysis. So, who responded to our survey? As already mentioned, we had 391 respondents ranging from all different specialties and location types. This slide breaks those down. Majority of our respondents said they were a general dentist at 70%, followed by orthodontics and dental facial orthopedics at 9%. Pediatric dentistry represented 8% of respondents. Oral and maxillofacial and dental public health represented 5% and 3% respectively. The other category represented specialties such as endodontics, prosthodontics, and dental anesthesiology. As for practice setting, the majority of our respondents were a solo practitioner with over half of our responding population. We're then followed by an employee dentist in a private practice or an associate at 11.3%. 8.4% were group partner DSO affiliated, while 7.8% were group partnership non-DSO affiliated. 6.7% were educational institutions. Government supported clinic came in at 4.9%. And the other category, as stated above, were practices that had locations for, or that practice for for-profit corporations, charitable healthcare settings, and those who are currently not practicing. The map on this slide represents the frequency distribution of survey-indicated dental practice locations. The light blue represents counties where there were 1 to 4 survey-indicated dental locations. The medium blue is 5 to 9 dental locations, and the darkest represents 10 or more locations. We received responses that had dental locations in 70% of the state. Okay, moving on to the Medicaid portion of our results. Less than half of our respondents accepted Medicaid at only 47.7%, while 52.3% did not accept Medicaid at all. For those who answered no to accepting Medicaid, only 36.8% indicated that they had ever accepted Medicaid at all at their office. This slide shows the responses we received when asked whether practice stopped accepting Medicaid. This question was only asked to those 36.8% who responded that their practice used to accept Medicaid but has now opted out. I'll give you a minute to look this over, but it is clear the top reasons were low reimbursement rates, attitude of MCOs, burdensome paperwork, and high patient no-show rates. Okay. We then asked those who currently accept Medicaid, which MCOs their practices accepted. The top 3 MCOs were WellCare, Aetna, and Passport. All of the MCOs were accepted, just some not as much as others, and this slide breaks that down. The next few slides, we'll look at Medicaid access to care. This survey question were asked to respondents who indicated that they currently accept Medicaid. The left is a chart that shows the breakdown of how many Medicaid patients are seen weekly at the dental practices. Most practices see anywhere from 0 to 60 Medicaid patients a week, with 56 and 55 total practices respectively. On the right, the pie chart indicates that 84.4% of practices are accepting new Medicaid patients at their office at this time. This slide shows the breakdown of age ranges seen at Medicaid dental practice locations, including both new and existing Medicaid patients. It is clear the adult Medicaid population is lacking as it does not reflect the same rate as children. Okay, this graph shows the times Medicaid patients can receive care at Medicaid dental practices. Majority of practices see Medicaid patients daily, all day, Monday through Friday. Almost 100% of our practice locations see Medicaid patients in the mornings, with a very high percentage in the afternoons. Saturday and Sunday, there were only 6 total dentists who responded that they work and see Medicaid patients these days. And like I said, this question was only asked to the people who responded that they take Medicaid. So this map here represents the frequency distribution of survey-indicated dental practice locations that accept Medicaid. The lighter blue indicates there's only 1 to 2 practice locations that accept Medicaid in that county. Medium blue is 3 to 4 locations, and dark blue indicates 5 or more Medicaid dental practice locations. A little over half of the state had at least 1 Medicaid dental practice location. 47% had no Medicaid dental practice at all, indicated by the gray on the map, and this was according to our survey results. Here's comparison of overall dental practice locations and Medicaid dental practice locations. You can see there are more gray counties on the right, meaning there are no Medicaid accepting dental practices in that area. And for those counties that are shaded light blue, there's only 1 to 2 offices that accept Medicaid, which makes it hard for those light blue Eastern Kentucky counties and any light blue county for that. I think this comparison shows the true need for Medicaid dental access to care improvement. For example, folks in Eastern Kentucky who are on Medicaid could potentially have to drive as far as an hour and a half just to be able to go to a general dentist. Make it a 2 to 3 hour commute if they need a specialty dentist. It's a barrier that we absolutely need to try to break through. This survey question was asked to all of the survey participants, regardless if they accepted Medicaid or not, because we wanted to know everyone's thoughts on this particular issue. We asked this in a forced choice approach, meaning the respondent had to commit to an answer. This type of question forced the respondent to provide a yes or no answer for each item without using bias. The top 3 challenges that 72% or more indicated was reimbursement, burdensome paperwork, and broken appointments, patient noncompliance. This mimics slide 6, where we were given the answers to why dental practices stopped at accepting Medicaid. I'll give you a couple of minutes to read through these blurbs that were submitted along with the surveys by our dentists. All these dentists have issues or negative experiences regarding Medicaid. These dentists are very passionate about the work they do and the treatment they provide this population of patients. But things must change to make this system work for everybody, not only the Medicaid population, but the dentists as well. You can feel their emotion and stress when reading some of these. Are there any questions for either Dr. McKee or myself?
I'd like to ask that the slides be made available, and I'll certainly want to study this a little more closely, but it's very helpful information, and I thank you for providing it.
Okay. If there's not any more questions, we thank you for listening to our presentation of our survey findings. Here's our contact information if you all would like to write it down should you have any comments, questions, or concerns.
This is Chris Kaiser. I just have a quick comment on the one slide which showed like why they weren't taking Medicaid. There, you know, it said something like, or there was like a graph that said no shows and things like that was very high. But then below it, it indicated that they didn't think patients had a problem getting, that there was a barrier of getting to the appointment. So I would be curious as to, you know, why then where are the no-shows? Why are there no-shows?
But yeah, that makes sense. Thank you for bringing that to our attention. We would like to know that answer as well.
And I think that would be patient interviews.
Yeah, I was going to say, so keep in mind that this is just a survey of the dentist
Dentist.
providers.
Their
But I
perception.
mean, you know, in primary care, if a patient no shows, you know, the doctor wants to know why they didn't keep their appointment. They're not just gonna say they didn't come with no follow-up. So somebody from the clinic is going to contact them to say, you missed your appointment. What's going on? Is there a reason for that? That kind of thing. So I'm just curious as to why the dentist office wouldn't do the same. Just reach out and do a courtesy call to the patient to say, you missed your appointment. Was there a particular reason? Was there a barrier or whatever, you know? So
Well, and
I think that's,
This Rainer, I would just observe that you're asking for a very deep dive into a very complex subject there, and that if you dig into it, there are multiple reasons. And I don't know of any of the practices that didn't routinely try to follow up and reduce no-shows. That's a topic of ongoing discussion, has been for years in the practice community. So it's not because they're not trying to understand it, but you come up with transportation, illness, work conflicts, all community factors associated with
sure,
social
but
determinants.
for the purposes of this survey, I'm just saying that if they're going to do this survey, you know, the dentists that were surveyed indicated a good majority said no, there wasn't any barrier because they couldn't, you know, of transportation, they couldn't find the place or get to the place. Well, then, you know, maybe the survey needs to dig into, you know, okay, besides the fact that they couldn't get to your place, you know, were you getting other information that indicated there were other barriers? I'm just saying for the purpose of the survey, it seemed a very narrow question for the dentist to just say, you know, do you feel like your patients had any barriers to getting to your office. Oh, no, I don't think that that's a problem whatsoever. Well, then, so.
Well, let me make one other comment. Dental fear is a huge consideration. And the fact that many of the Medicaid patients do not have an established dental home.
Sure.
And if they're geographically far away from a potential practice and they're seeking emergency care, oftentimes they reach out to multiple practices even to try to get seen. And if they get a problem solved one where they follow up and cancel the appointment another, this gets really entangled in a whole set of experiences with a chronic, painful problem that adults experience. And so that's that. I'd stop. I want to hear what Veronica has to say about the Medicaid things, but this is one of the reasons it complicates dentist participation as well as patient access to care. No question about it. Julie, I see you shaking your head. I know you agree. You and I have talked about this for years.
Yeah, we have. And this is our first dive into surveying dentists, and I really don't think it's going to be our last, because we'll have good questions to compare last year to next year, things like that. But I think that trying to dive into that is a good idea. Checking on missed appointments, private practices checking on missed appointments, that's kind of a spotty practice. That's not seen a whole lot. It is not a regular routine for overall care. It's just a missed appointment.
Let me speak up here and say that I think one of the comments from one of the dentists in there is part of the problem when he said that they didn't have appointments available anywhere till over 6 months out. And by that time, many things have been resolved either by going to a different dental practice or just forgetting about it or whatever. And that's one of the problems we have in our practice, except for a plan of treatment. We do not make appointments beyond 2 weeks. What we do is to develop a list so that each week, as 1 week is gone, then for 2 weeks ahead, we call the people on order on that list and ask them if they're still interested in making an appointment for that upcoming week. So it's a more fresher event. It's not waiting for someone that was scheduled 5 months ago to see whether or not they show up. I cannot give you stats, but the dentist works for me have said that it is better on the no-show rate than what it was before.
Yeah, I was going to add, so as you all, I believe we added a no-show reporting option in the Kentucky Health Net, and Dr. McKee, it's information we'd be happy to share with you. I get we've heard from providers, I don't have time to do that, and I totally understand that, but this highlights the importance of it. What it has been able to show is if there's a person who is chronically canceling or missing appointments, is even if we don't know the reason why through the reporting, we can give that to the MCO, and the MCO can outreach to that person and find out what's going on. I think, Rainer, you make a great point that when it comes to dental service, there is fear there. And that, I don't think is specific to dentists, but because there's, I think, fear of going to doctors, people have those fears. But if it is transportation or childcare or, we've heard that the appointments available to the Medicaid beneficiaries are those appointments that nobody else wants. They're made available. And I'm not trying to do a broad brush on that, but those things are happening too. And so what we prefer to do is let's figure out who is having the challenge of getting to their appointments, whether it be dental or whatever, and how do we help that person address any barriers that might be going on to those. And that's the whole point of the no-show report. You know, we're seeing an uptick in reporting along those lines. And every month we send that report to the MCOs about their members so they can see. And again, the expectation there is to have them outreach and see what might the barriers be to meeting those appointments.
Veronica, just a quick comment. It's not only the no-shows, it's the half of the beneficiaries who have not been in contact with the system at all, that many of whom have chronic problems. And so I would just observe that the use of case management in dentistry is way below where it needs to be. And that's something that could be addressed through the MCO mechanisms. And I hope, you know, as we proceed with these discussions, that we'll think about. One of the other things that comes to mind for me in the transcript, I noticed you said a lot of these factors are beyond Medicaid's control. I certainly agree with that. They do reside in many cases in the communities, but Medicaid also has substantial leverage with the MCOs that they can apply to begin to help address these problems in ways that they've not previously. So again, I hope as we proceed, we'll be thinking about how can we use the leverage of the program to influence not only dental services, but access to other services like the doula discussion that we just had. Because oral health is integrated with all these services. The integration issue is another important piece of this. So I'll stop. Let's hear some Medicaid data and unless others have questions.
Well, just one other thing to follow up with that, my comments were primarily around workforce. So, and Dr. McKee might be able to speak to this, but my understanding is the workforce has declined. And in those dentists that might be licensed or not practicing or practicing full time. And so there's an overall workforce shortage, and not just in dental services, but in a lot of our services that I think the solution to that is beyond Medicaid. And it has to come from, you know, other incentives out there that Kentucky can do to try to encourage both individuals going through school and graduating and then staying in the state, or attracting them from other states. I think is a challenge we have. We do have, you know, we have some tools in our toolkit that might be able to help them enroll in Medicaid. And, you know, those things include reducing administrative burden and increasing provider rates. But even those tools come at a cost for us, and that's what we have to, you know, balance with overall our budget. So I'm gonna share. And I will say that it is always a challenge to do a PowerPoint on. So let me see if I can get this to do right. Okay, you all see my PowerPoint?
Yes.
Great, thank you. I'm going to turn my video. I want to see here if I can. Now I'll leave it on. Okay. So just very quickly on a high level, there was a 2020 workforce update, and it estimated that there were around 2,733 practicing dentists in Kentucky in 2020. So that's one dentist for every 1,952 Kentuckians. That's a big ratio. And in the rural areas, that fell to 1 in every 3,288 for all Kentucky. And then in Appalachian area, that's 1 in every 2,946. So we already recognize that in our rural areas, and as you all saw in the survey through the responses, that there are gaps across our state. And that's absolutely concerning to us in Medicaid. I wanted to share, so the dental benefit is not a mandatory coverage. So states can elect to cover dental services. And of course, Kentucky absolutely elected it a long time ago, and we've been providing it a long time. We have a robust children's benefit because of requirements to cover any medically necessary services of our children. And then we've had a limited benefit, which is what this slide reflects, is that Kentucky has had a limited benefit for adults, except beginning January 1st, we have expanded the benefits available to adults. And I think this, if we can increase our participation and decrease our no-show rates, I think this has an opportunity to provide some really improved outcomes for our members. We're going to go to 2 cleanings a year. Right now, we cover 1 for adults, but we're going to start covering dentures and root canals and crowns. What we're trying to do is, I think as you all, if we noted in conversation, is that a lot of people go to the ER for their dental care, and we're trying to prevent that from happening. And I think, Rainer, to your point, we want people to have a dental home. It's important for them to have regular preventive care, and then to have acute care when needed. So we're excited about this expansion, these new benefits. And what we did decide to do to encourage provider participation is that we are going to cover these at the child-specific fee schedule, which is a little bit higher than the adult fee schedule. And this shows you, sorry about that, this shows you Kentucky is the highest reimbursement for dental services for children. We're at 104.8% of the commercial rate. So, you know, I know we hear a lot about increasing reimbursement, but we're doing pretty good in terms of being equal to what is paid under commercial. So what this means is that for those dental services that we've expanded for adults, they will also mirror this reimbursement. So what does our dental network look like? And again, this is a shot of 2020. We had 2,733 enrolled. Of those, 1,585 were paneled. And then I think what is most concerned to us and what we continue to deep dive into is we only had 997 actually bill in 2020. This is a map that shows you per 10,000 Medicaid beneficiaries where our dentists are, and you can see the darker blue are higher. So that's 12.87 dentists per 10,000 residents for Fayette, 9.63 dentists per 10,000 residents for Jefferson. But the concern is these zeros, right? We have a lot of zeros, and zeros are bad. So that's where Medicaid beneficiaries have to travel to get access to care, and that's a barrier. You're not gonna get participation and access to care if you're gonna have to travel far to get to that. So that's something we need to work on. This shows a growth in the enrollment in Medicaid. The blue is those providers who are billed. The green is those providers who were paneled. So as you can see, that disparity is growing between who we have paneled and who is actually billing. And that's really what we're looking to deep dive into and see what's going on there. And again, you know, what we note from all that information and data that we looked at is that it's these counties that are struggling to, for dental care, for dental services, for dentists that are on Medicaid and billing. And those are the ones that we really need to concentrate on, because that's a disparity that shouldn't be. Then we're going to look at utilization. In the 2021, Kentucky ranked 49th in the percentage of adults who visited a dentist. And that's pretty bad. So it's not good to be 49th. So only 57.2% of our of adults in Kentucky. I know this is all adults, not just Medicaid. In Kentucky, these are the services that our beneficiaries are accessing. So, and the total spend for that code. So as you see here, number one was orthodontic treatment for children. We had 11,000, over 11,000 beneficiaries who access that. And it is our most expensive at $22 million. But, and again, a lot of this is child. It'll be nice to see once we expand the benefit January 1, what this looks like in a year, to see if we've seen growth in obviously the access to adult services, necessary services. So total spend was $248 million.
Could you go back to that slide?
Yeah.
Did you say 248 or 138?
No,
Oh, that's top 10.
total
Okay.
dollars. So this is top 10. So total of the top 10 dental codes was 138 million, but total spend for dental was 248 million.
Okay. Thank you.
Yeah. And this presentation will be shared too afterwards. What we saw is Medicaid beneficiaries in the first 2 years of the pandemic. We all know that really there in 2020 that most dental offices had to close, and so utilization dropped significantly. And dentists were really only seeing people for emergency situations, and even then, I think a lot of people were diverted to ERs. Because the dentists, I mean, we still didn't know a whole lot about COVID and how to protect practitioners. And so we saw a huge decrease. So 27.5% of beneficiaries saw a dentist during that period of time. We also wanted to show where, who is doing the most in terms of dental services. And these are the top 10 counties where the highest percentage of Medicaid beneficiaries receive at least one dental visit. 37.6% is not something to brag on. So it's still really low. But as you see, it's an interesting mix of counties. And I think that has something to do with the providers in those areas, really working hard to try to provide that access to our beneficiaries. And then these are the ones with the lowest. So these are the bottom 10 in terms of where we're seeing access to or the reporting or billing of a dental service during that period of time. And Letchers, they're on the bottom at 6.36%. The last thing I just wanted to touch on is, we are worried and concerned and want to do what we can to increase access to oral health. I think we all recognize that access to oral health is improvement in overall health and has the opportunity to improve overall health. So Medicaid has available to them what's called a state university partnership program, or SUP. And it's only available to universities. And universities then partner with the state Medicaid agency, and they can do deep dives into different areas of research. Sometimes the universities approach Medicaid and say, look, we're really interested in this particular health outcome or health service and want to do some research around it. And so we'll provide that data to them to give them the opportunity to promote their research. What we've really moved to over the past year is handling it differently. And that's where the state Medicaid agency, DMS, is reaching out to the universities and saying, we want to know about this. So we are anticipating using this program to continue looking at oral health in Kentucky and identifying both, the barriers and making more data informed decisions about what can we do. So one, there was research was funded in 2020. It was at the University of Louisville under Dr. Vu, and they looked at the association between oral health and myocardial infarction, pneumonia, asthma, chronic kidney disease, rheumatoid arthritis, hepatitis C in adults with type 2 diabetes. And what their results of that is that it does suggest that dental care can help prevent heart attacks in patients with diabetes. So we wanted just to show this as an example of what we can do in terms of, really trying to get an idea of what oral health benefits can be, and then also identify what can we do to improve outcomes from it. So that is.
Okay, Veronica, have you all looked at the issue then from standpoint of dental schools and retention rates on those graduating from dental schools in Kentucky?
We have not. We're trying to be more focused on what are Medicaid policies and programs that we have control over and can do to try to encourage use of the preventive care and enrollment of Medicaid providers. But that doesn't say that we could not use one of our state university partnership research programs to look at that. And I don't know, Dr. McKee, if you all from public health are looking at that.
No, but it's something I've wanted to look at, and that would not be a difficult project for us to do and get back with you pretty soon. Just talking to some particular contacts in the dental schools to find out where the new graduates are going to go. Now, here's the most difficult part. It's hard to trace them where they are 5 years from now, because what that may do is, for example, Julie McKee may be graduating in 2023, and she's going to ortho school in Missouri. So she's not going to be a dentist in Kentucky. But what we don't know is after she finishes her residency, does she land back in Kentucky? But the dental schools might have an idea. They keep up with their alumni. They might have an idea about how we could query them 5 years down the road.
Okay. That's a nice transition into some comments I'd like to make, if you'd permit me to do that. This is one of the most encouraging discussions I've had in a while, and I thank you for sharing the information. There's also a bit of frustration because I don't want to go too far in the past, but I do want to just put something on the record. We started down the road of trying to really improve oral health information with the state in 2010 through research that was funded by former Governor Steve Beshear through the Appalachian Regional Commission and in partnership with Medicaid and, Julie, you'll recall, with the state oral health program. And this was a comprehensive effort with the Kentucky Dental Association as a full partner and the Hygiene Association to develop improved oral health information for the Commonwealth. And it actually took us 2 years to figure out how to accurately count dentist and dentist participation in Medicaid. And Julie is shaking her head, she remembers. And we had very comprehensive data, trend data from 2010 through 2016. Veronica, one of my frustrations in this is you do need longitudinal data, accurate data to build good oral health policy. And it seems that we've diverted off the track at trying to recreate the wheel again, when a lot of investment was made by the Commonwealth to develop improved oral health information. And we had a good approach started to at least inform the process. And so I'd like to make a plea to replicate that work from 2016 to 2022 so that you could see what's happened actually over the past decade. I do have several questions about the numbers that I saw there based on my involvement in that work for several years with dental licensure data. There's some surprising numbers on there, I'll just say that, and I'd want to get a better understanding to determine their accuracy. But I'm not saying they're not, I'm just saying they're very surprising to me. So I would hope that we might be able to talk about establishing a new collaborative model to improve oral health information and address some of these questions, again, with Medicaid, the state universities. And apart from individual research questions like the impact of oral health on diabetes, but it seems to me that dental workforce information ought to be an ongoing activity so that you could measure trends and longitudinal activity and their basis on policy. I would just also observe that two of the most significant things that have happened in the state of Kentucky related to oral health have happened in the last, or three actually in the last year. The first is this recent expansion of Medicaid. I mean, that's a game changer, but it's also going to put tremendous stress and strains on an already deficient oral health workforce. Mm-hmm. And I believe that calls for a comprehensive look at dental workforce in Kentucky and on dental education policy. You can't treat one separately in a silo. You've got to look at them together. And you've got to look at them, I believe, in combination with the MCO reimbursement for dental care. And the reason I say that is all of my recent conversations with my colleagues in dental education indicate not only are dental practitioners suffering from the reimbursement rates, dental education's institutions in the state are also suffering. The current model for funding dental education is not going to be sustainable. And it's primarily due to inflation and the reimbursement rates. My colleagues tell me that every time a College of Dentistry sees a Medicaid patient, they're losing money. So the more they try to respond and help when patients seek care from the dental college, the bigger financial hole they dig for themselves. And that's obviously not a sustainable model or an appropriate model. And so, Veronica, there must be much more detail underlying these reimbursement rates than is obvious right at this point. And I think it does command a deep dive. The other thing that's obviously happened is the entry of UPAC into the dental education system in Kentucky. And that's a very positive development, and but it's also going to impact workforce policy and access to care. That again suggests to me that this needs to get up on a much higher priority list to look at workforce trends, workforce policy, and try to develop a plan to put the state on a more positive path regarding oral health and their integration with other aspects of primary care, medical and behavioral. It's all related. So I'll stop. I'm not trying to lecture anyone. I'm just saying this is very encouraging, but I think it needs to go a step further. I think you need to measure longitudinal trends in a consistent way and take it the next step to develop specific policies to address problems that we know are there in the system. So
Okay, let me step in and put on my chairperson hat here. This is a very important issue, and obviously by the breadth and the extensive discussion that we have, this may not be the best format for that.
I agree, but we have at least surfaced the problem. Yeah.
Veronica, to that end, would the department consider setting up a workshop specifically for this dental and let those of us with an interest or stakeholders be part of that, kind of reminiscent of what we're doing about the RAP?
So that's a secretary of the cabinet decision and a request that I mentioned to him previously. You know, I think wanted to present some information and get some feedback, which is the purpose of this meeting. You know, I think Dr. McKee, obviously, in her role, would play a big part of that. And so I'm happy to take the request back to the secretary and you know, pursue that. You know, Rainer, I think one of the challenges with our system is that administrations come and go. And it's as equally as frustrating to us sometimes when we're doing the work and then priorities change that we have no control over. And so that certainly has happened, I think, in the change of administrations over the past 2 decades. You know, we can certainly go back and pull and look for that information that you referenced, but I agree with you, Mike, in terms of this is probably something beyond the tax jurisdiction and ability, and happy to take that question back to the secretary about the creation of a more cabinet workforce.
Okay.
I'd like to make that recommendation.
Now okay, you want to make that as a recommendation to the MAC then, Renard?
Yes, I would propose that we request that the cabinet convene a group of dental stakeholders to look at policy matters and information related to policy, in support of policy, related to dental workforce and dental education in the Commonwealth. That I may not have phrased that exactly succinctly, but I think the intent is clear.
Okay.
I'll second that, Rainer. This is Barry.
You made a motion or second to that effect, Barry?
Yes. Yes, sir.
Okay. All right. So that'll be a recommendation to the MAC if the board approves it. All those in favor of the recommendation as stated by Raynard being presented to the MAC, please say aye.
Aye.
Aye. All those opposed say nay. Motion carries unanimously, and that will be our recommendation to the MAC under item 8. Now,
Mike, I'll be happy to try to edit that a little more succinctly if you'd
Okay.
like to do that for me. Like
do
I did.
that, and when we come to number 8 on the agenda, then we'll let you read it into the record, okay?
Okay.
All right, now, we're about 20 minutes away from 12. I'd like to get us back on schedule, which means we'll be moving through the other agenda fairly quickly. Let me say that Carla Townsend on that subject is got a message there for adult expanded coverage in January 23 is a lab cost for dentures being considered when reimbursement is being calculated. She also comments another issue we find in their offices are referrals of Medicaid patients when the specialists do not accept Medicaid. And Judy Thoreau says, how do you know what the barrier was if you don't call and ask? Not going to apply to those. Good questions, good comments, but we are going to move through and get through this agenda by 12, okay? To that end, then, the establishment under 5G, establishment of core quality indicators that will become uniform between all MCOs, Division of Quality and Population Health by Angie Parker, and Angie is the director of DMS's Division of Quality and Population Health. Angie, are you going to be presenting on that one?
Yes, sir. Good
All right.
morning. I am Angie Parker with the Department for Medicaid Services, and as you said, I am the Director of Quality and Population Health. I realized this was brought up at the last meeting, and I was not in attendance, but I did have a follow-up discussion with Molly Lewis and Dr. Steve Hoagland regarding the challenges that you're having with all the different MCOs having different value-based contracts and quality indicators that you are responsible for. We had that conversation, and they have shared what the different quality programs that each MCO has with us. So that is under review and seeing how we can potentially assist in normalizing those types of quality measures that each provider is being asked to align with each MCO. So that's in progress. It's one of those things, again, that takes a little time, but we are certainly looking at that.
Do you have a timetable that you're looking at as realistic?
Well, I wouldn't say before the first of the year. As I don't know, has been discussed in here, but with the reorganization within Medicaid that it was effective in July, this is a new division of Quality and Population Health in which we are, we have an established quality branch, but we're also in the process of establishing a population health, an equity and determinants of health branch, as well as a research and analytics branch. So all of those sources will be pulled together and hopefully be able to continue the quality work as we just completed the quality strategy, and that is getting ready to be submitted to CMS, and looking at all of the quality indicators that our MCOs are doing, and assuring that we are appropriately and adequately evaluating and all of the quality measures that each of our providers are asked to perform.
Okay,
So long story short, I don't have it. Long story short, hopefully the first of the year we'll be able to kind of really look at those and see how we can.
Okay, we next meet on January the 5th. Could you come back then and give us an update?
I sure can. Yes, sir.
All right. Is there any questions of Ms. Parker? Okay, then let's move on then to 5H, update on emergency credentialing by Veronica Judy Cecil and Molly Lewis. And the reason we do that is Veronica was going to follow up dealing with Medicaid credentialing, and would like for Molly to speak to what's happening on the FTCA side as it relates to the emergency credentialing. Veronica, do you want to go forward on that one?
I believe Jennifer Dudinsky.
Yes, I'm on. This is Jennifer Dudinsky. I'm the director of the Division of Program Integrity and Enrollment is housed in my area. And I don't know if Molly's on, but I think we had a little bit of trouble getting the right connections in place to kind of talk through this. But my understanding is we've connected with the right people and are working towards making sure that we have a process in place for emergency credentialing when disasters and things of that sort of nature occur. We, of course, in Program Integrity want to work, collaboratively with you all. And when we do have disasters that strike, that we're able to meet our members' needs and provider needs when those things occur. So in terms of, what the discussion was, is that when when disaster strikes and there's an emergency situation, make contact immediately with our enrollment team, and we will work to get emergency credentialing rolling as quickly as possible. I think the major concern was surrounding a date that something could be implemented and whether or not we can backdate providers with groups. So, and we can certainly do that when the circumstances are as such. And as long as all of our requirements are met, we can backdate those providers so that we can ensure that they get paid for the services that they're providing when those emergency situations strike. So that's kind of the update I have right now. I know that Molly or members that Molly connected with my team have also been talking and working as recent as yesterday. So I don't know if Molly's on and has anything to add or if there's any questions.
I think part of the thing was under the regulations right now. You mentioned comply with regulation. I think part of the problem is regulations right now are cumbersome and not appropriate to an emergency situation because of the documents have to be required. And, it's kind of hard to provide you documents when I'm sitting out and looking at 3 foot of water going down Main Street with boats instead of cars on it. That was some of the comments last time. And certainly I've experienced this. What we're looking at is we want to be able to have a point of contact however we can and say, look, we need to do this with this provider, and we're going to comply with all your regulations, but give us 30 days to do so, to get our feet under us, so that we can do it and we can go ahead and provide the care for our people who's lost medicine, and because it's kind of hard to hold on to a lot when you're climbing up your trellis trying to get to the roof because the water's halfway up on your 90. So that was the comments last time. And this is what I hope that the department is looking for, is making abbreviated regulations like this that is appropriate in the case of an emergency, like what happened here on July the 28th and what happened in Maytown back earlier in the year. And it's reality versus regulations. And we saw people in a gymnasium on the day following the flood and had 175 people came in with hurts and injuries and lost medications and trauma and stress and you name the whole ball game. And so we have to make sure that it's in place, that we're going to be able to see those people and just to heck with the regulation, because we got to take care of people. And this is one instance when the regulation needs to be wrote in such a way that it facilitates us, not hurt us in being able to do so.
Thank you for that. I understand and appreciate those words. And we are looking at our regulation. I've been looking at all the regulations that are kind of housed within program integrity. So we are looking at those regulations and looking to make any changes that we feel are necessary in regard to that, because we certainly want for providers to be able to provide services in those situations and to make sure that, that we're doing our best to facilitate that. And like I said yesterday, I know that we'd had some trouble kind of getting the right people connected to talk about the specifics with the documentation and those sorts of things. And I believe yesterday we kind of finally resolved that issue. So I'm sure there's going to be some additional information as we continue to work through it.
Okay, thank you so much. Molly, are you on here?
Mike, I don't think Molly's on here, but I was the one that spoke with SAPNA at length yesterday about this and explained exactly what you just said. So the conversation is continuing, and she indicated that she would be the point of contact to reach out to, and they would definitely backdate should an emergency situation arise, as long as, the legal requirements are met, that they're a doctor and credentialed and everything, but they would work with us and we could reach out to her specifically with those requests.
Okay, we'll go to any other old business. All right, then we will go to new business under 6. And under 6A, dates for primary care. And those have been presented and they're listed there on your agenda as January the 5th, March the 2nd, May the 4th, July the 6th, September the 7th, and November the 2nd of 2023. Any comments about that? Then we'll go to new business B, and we've already had that, which is presentation by Dr. Julie McKay. And thank you, ma'am, for doing that. C is the doula presentation by Dr. Julie Richardson, and thank you, Julie, for doing that. 6D is update on new regulations regarding presumptive eligibility, DMS. Who will be taking that for Medicaid services?
So this is new business and we have no idea what this is about.
Well, it's really new, isn't it? Okay. All right, I don't either. It's on the agenda. I'm not the one that put it on there. Teresa, can you, Cooper, can you help us?
I believe there was some new legislation regulations passed that extended presumptive eligibility. I think the TAC, someone on the TAC had just requested clarification on what that was going to be.
Does that give you enough to address, Veronica?
No, I can tell you about presumptive eligibility. Now, House Bill 7 passed in the 2022 General Assembly general session, prevented the state from no longer being able to be a qualified entity to designate presumptive eligibility. So we did remove that July 1 in accordance with the law. And we took down our COVID-19 temporary presumptive eligibility application. Now, so we reverted back to the old presumptive eligibility requirements, which is primarily through a hospital or FQHCs and RHCs, I think, can do some PE. Our two, under the public health emergency, we still have our 2 presumptive eligibility benefits per year, calendar year. So somebody could, have potentially 4 months of presumptive eligibility coverage if they access both periods during the calendar year. But I'm not sure beyond that what this might be pertaining to.
Okay, so whoever recommended that to be put on the agenda, if you could come back and give us more information, we will go into that in our January meeting in more detail if Veronica's explanation did not satisfy all your interest. Then we go to number 7, reports from the MCOs. My apologies, we're running short on time. Would you care to make your reports brief? And we'll start out with United.
And Mike, did you want them to address D under old business about the monoclonal code for outpatient setting?
The what now?
Under old business D, so it said update from MCOs on monoclonal code. I don't think we touched, I don't think we covered that.
Veronica, I can report on that because it stemmed from, I guess, my concern. They have responded appropriately and in kind and very promptly. So I think everything's going good with that.
All right, thank you. Sorry, Mike, to interrupt.
And I apologize for having missed that. Okay, United with MCOs, who's speaking for you, please?
Good afternoon, Chairperson. My name is Chris Kern with United Healthcare. Can everyone hear me?
Yes, sir. Go right ahead.
Okay. I'd like to present some updates. In the previous 3 months, the United Healthcare Community Plan has partnered with Walgreens and Park Duval and 10 community events across the Louisville area to provide COVID-19 as well as flu vaccinations. Over 100 vaccinations were administered, including 20 first doses. Our plan is organized immunization and logistics for these events, which included health resource fairs, back to school events, and goodwill opportunity expos and expungement clinics. And we sponsored all of these events. We had our Q3 QMAC with members, and 15-member education series that focused on upcoming benefits for members, as well as existing incentives for promoting healthy lifestyles and financial rewards for receiving vaccinations. On October 10th through the 12th, we attended the Kentucky Primary Care Association Conference. Had an opportunity to meet and network with many key staff members from Kentucky's FQHCs. And we identified in those collaborations areas where we potentially could collaborate to promote healthy lifestyles and health outcomes for our members. And we also had an opportunity to listen to those providers for what was working versus what was not working when it comes to working with United Healthcare Community Plan, and we'll continue those collaborations. That's my report. Ask if there's any questions.
Thank you, Chris. Are there any questions for him? All right, we'll move to WellCare.
Hi, Mike. Our next WellCare informational webinar that I host bi-weekly on November the 11th, Darren Levitz is going to be my co-host, and Darren's going to be talking about the new and updated 2023 Medicaid member benefits. So this is a forum I've been hosting for a number of years, and if anybody needs an invite, just send me an email and I'll be happy to share. Thank you so much.
Thank you, sir. Any questions for Johnny? All right, Humana.
Hi, this is Daryl Van Cleve with Humana. I was on Tuesday, November the 1st, Humana's provider engagement professionals sent out our Q4 physicians newsletter to all our primary care physician partners, as well as sent out the updated Medicaid COVID-19 FAQ that we received from DMS. And that concludes the Humana update.
Thank you, sir. Any questions for Daryl? Passport Molina.
Hi, this is Yolanda Callagher with Passport Health Plan by Molina. This week we have ribbon cutting ceremonies for two of our one-stop health centers in Covington and Owensboro. Now all of our one-stop health centers are open and ready for use. We have those in Lexington, Covington, Owensboro, Hazard, and Bowling Green. If anyone's interested and you'd like to utilize one of our facilities for training or education, please reach out or we'd be happy to give you a tour. Also, Passport Health Plan by Molina, we're getting a new look and a new name, Passport by Molina Healthcare. We will continue to work hard to move into the new look this fall. You might see our old logo on some materials we send you and our new one on others. This just means that we're transitioning and in the process of changing over. What isn't changing is our commitment to you, our patients, your patients, and our members. Thank you.
Thank you so much. For any questions for Yolanda? All right, Anthem.
Hello, everybody. It's Brian Richardson with Anthem. Just wanted to share that we have instituted a tobacco cessation program, and you can find that on the website of anthem.com under providers. I'm also going to place the link in the chat for everyone that you can share with your providers, but we'd love to be able to promote that and have referrals going and getting different people to join the program. That's all we have.
Thank you, Brian.
Thank you.
Any questions for Brian? Aetna.
Good afternoon. This is Jacqueline Pack with Aetna Better Health of Kentucky. Pleasure to be with each of you this afternoon. It's been a little bit since I had been able to attend a primary care TAC. Ms. Rebecca Markham is in a specialized training today, so I'm sitting in for her. I do want to say that we've had some wonderful trainings over the last 3 weeks in October for autism, specific training virtually for providers and family members. We've covered autism and co-occurring disorders, supporting children through puberty during an autism diagnosis, also teaching of social skills. That was an excellent training. And we did just finish the on the 2nd, that was just yesterday, how the sense and behavioral go hand in hand for autism. So we have been very excited about that training. Many folks attended those. We are looking at going into in-person trainings, of course, in 2023, according to how the public health emergency continues to pan out for us. But keep watching for those virtual training opportunities. They're excellent to fit into your day. Grab some lunch, sit in on those, and especially for the SCI population, those are highly specialized in needs. Also, evidence-based guidelines for children and adolescent obesity training. We just had a series kick off on that, so be watching for those as well. We had provided the crosswalk pertaining to the side benefits this morning to Aaron and Jeremy, so I anticipate you'll see those from Aetna Better Health of Kentucky. Thanks so much for your time. I've appreciated this today.
Thank you, Jacqueline. Any questions for Jacqueline? Let me say that when you're talking about autism, you're going straight to my heart. I have a grandson who's autistic, and I'd love to see maybe you'd be willing to do a presentation and go on the agenda for one of these, or maybe get Mr. Curry with the public health to join in on that.
Fantastic, Mike. Thanks for that opportunity. I will certainly take that back.
Okay, and let me also say that as the recipient of a lot of reaching out and a lot of aid due to the disaster flooding that happened in Eastern Kentucky, that I want to thank the MCOs and their efforts during that East Kentucky flood. It was fantastic, the reach out, the help, financial materials that you all did, and it really made me proud of you all as all separate, but as a group organizations on how you rose to the forefront to certainly help us. It does kind of show something that when the Maytown tornadoes hit, we we're setting up here within a 32-foot food van and was ready to put it into motion, and never could make the right connection. Tried through KPCA, referred to the state. They said they'll have someone call me back. 2 days later, no one had called, no one called back. And I think that's an area that we need to work on, whether it's emergency phone trees or whatever. And by the way, that 32-foot complete kitchen ended up in the middle of the Kentucky River with 15, 20 foot of water flowing over it during this. But just a comment about that scenario that we need to work in. And I don't mean to make this meeting into my personal meeting. So let me go then to item 8, recommendation to the MAC. And I think Raynard, you wanted to word your recommendation for that.
Yes, I'm prepared to read that into the record.
Please go ahead.
The primary care TAC recommends the Secretary of the Cabinet for Health and Family Services convene dental and public stakeholders to study and improve oral health, MCO, dental education, and workforce information and policy. And I further added a sentence: dental auxiliary participation in the public health and dental practice delivery of dental services should be included. And the reason I add that is it occurred to me, based on recent information that I've seen, that we haven't been discussing at all the workforce crisis involving dental auxiliaries in Kentucky. But there's a lot of emerging information to suggest that dental hygienists and dental assistants, that we also have a workforce crisis related to those. These things need to be studied together. So I'll stop and ask that the TAC approve that recommendation.
Let me add to that we can't we can't to the MAC instruct the commission to do something. We have to word it in such a way that we're asking the MAC.
So yeah, ask the MAC to recommend to the secretary.
Yep.
So amended.
Okay, let's just go through a vote on this again. Is there a, I'll take that Raynard is making that motion. And is there a second to that? Barry, I believe you seconded it last time.
I did second it. So yes,
Okay.
I'll second it again.
All right, all those members in favor of the recommendation to the MAC as read by Raynard Mullins, please say aye.
Aye.
All those opposed? Motion carries. Thank you, Raynard. Next item is 9, which is MAC meeting representation. The next meeting of the MAC is November the 17th. It'll be at 10 a.m. And as chairperson, I will be representing the primary care TAC committee at that time. Next item is number 10, and that is our next meeting, which will be January the 5th at 10 a.m. and it'll be a virtual meeting. And then the next item is adjournment. Do I have a motion to that effect?
So moved.
Okay.
And motion and second. All those in favor say aye.
Aye.
Thank you for your time, and I apologize that we have gone over here a few minutes.
It's a good meeting. Thank you, Mike.
Good meeting.
Thanks to everyone.
Thank you, Mike.
Have a good day, everyone.
Hey, thank you all.